This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
So welcome to our podcast, Remote Monitoring in Patients with Congestive Heart Failure. With me is Dr. Mustafa Ahmed, who's Director of the Interventional and Structural Program at the University of Alabama Birmingham. And our guest today is Dr. Jason Guichard, who's an advanced heart failure and transplant cardiologist at Prisma Health in South Carolina. Gentlemen, thank you very much. And I have to say, actually, we do record these podcasts on Sunday. So here we are, June 21st, the first day of summer. And it's also Father's Day. So I think it says a lot. You know, a lot of dads like to kind of play some golf. And here we have some physicians, fathers, that really enjoy getting together and kind of discuss on the web, on the cloud, about how to improve our patients' condition and how could we, push forward new technologies that can improve patient care. Thank you very much, gentlemen. So the remote monitoring of patients of heart failure, how timely is that? We wish we had more patients that were monitored remotely, particularly with COVID-19 and distancing. How great would it be if we had thousands of patients that we could monitor from home, and particularly that we have so many patients with congestive heart failure. Yes, Mustafa?
So what is remote monitoring? Like, how would you best describe this? Just for people that don't understand as well.
Great question, Jason.
Yeah. So remote monitoring, I guess, kind of the simplest definition is monitoring people outside of normal healthcare settings. So outside of your traditional offices or healthcare buildings. There are various different ways to do remote monitoring, as you might imagine, anything from just a simple FaceTime interaction to various devices that are implanted that we'll get to in a second. So I guess just kind of the very broad definition is basically any sort of patient monitoring or patient interactions or patient care outside of the traditional in-office or in a healthcare facility setting.
So we have actually patients with heart failure that unfortunately start decompensating and they end up in the hospital. As we know, every time we have a patient coming to the hospital, it's an increase in the risk of mortality. With each admission, there's an increase in mortality. So if we had a way to prevent hospitalization in patients with heart failure, this would be obviously a great advantage. And this is what the studies have shown, that if you can monitor patients with heart failure, you can actually predict, the patient decompensating and prevent these hospital admissions. So about 10 to 12 years ago, we got involved in this clinical trial called Champion, and it was the monitoring of pulmonary artery pressure. So Dr. Guichard, if you could tell us more about the monitoring of the pulmonary artery. What is this about? How do you do that? And tell us a little bit more about what it can accomplish.
Sure, absolutely. So this really is a passion of mine. Remote patient monitoring is something that I have become very aware of since 2011 when the Champion trial was first published in Lancet. At that time, I was a fellow, a trainee, if you will. And towards the end of my training, I made it a point to kind of learn these techniques, and because I realized the importance of them, being able to keep people out of the hospital for our heart failure population. So, heart failure has devastating, public health consequences. Just a little bit of background, there's about 5.7 million patients with heart failure, and about 1.5 million with advanced stages of heart failure. These patients require a lot of healthcare resources. As a matter of fact, about $70 billion are projected to be spent in heart failure by 2030. And about 50% of those, so 50% of the $70 billion is actually largely attributed to hospitalization. So the lowest hanging fruit from a cost, and as we will see from a mortality standpoint, from a death standpoint, is actually targeting heart failure hospitalizations. So really the goal of any remote patient monitoring program, but specifically the CardioMEMS heart failure system, which is made by Abbott, is to maintain a patient's fluid status. So one of the issues with heart failure, giving kind of a basic background, is fluid accumulation. So this is the standard thing, swelling in someone's legs, swelling in their belly, swelling in their face, fluid in their lungs, which causes them to be short-winded, have weight gain, feel tired, fatigued, lethargic. These are all the kind of constellation of symptoms that heart failure patients have, largely due to increased fluid retention. And we know that drives symptoms, and then that drives people to feel bad and then end up in the hospital. So the idea was born that if we could measure how much fluid is inside someone's body, then we could be able to act on that information. And that's how the pulmonary artery pressure sensors, the thought of that was born. So if we could somehow insert a device into somebody's body that measures the amount of fluid in their body and can send that information to us in the office, we could monitor this closely and make medicine adjustments if we needed to. So really the goal is to maintain fluid volume, to avoid what we call acute decompensation and hospitalization, and being more proactive with heart failure patients rather than reactive, reacting to their symptoms. We know that patients carry fluid on them. I think as physicians and cardiologists, we generally don't do a very good job, what we call decongesting patients, or making sure that the fluid level in patients are low. There's been multiple studies that have been shown that, about 90% of patients who are hospitalized still have a degree of actually fluid retention on them by the time they leave a hospitalization. And about 40% of them have moderate to severe fluid levels still in them, and actually sometimes went the wrong way during the hospitalization. So heart failure patients can be, tricky to manage, which is why we need resources outside the hospital in which to manage them. And one of those ways is what we call the pulmonary artery pressure sensor monitoring. So what is that exactly? So it's a little device. You can probably look it up on Google, CardioMEMS technology. It's a little device about the size of a thumbnail, about the size of a dime, or a quarter when it's fully expanded, that actually goes in one of the areas of the heart that measures the amount of fluid that's in the body. So it goes into the left pulmonary artery, and the sensor itself has a highly developed electronics that turn electronic measurements into pressure measurements. So it actually monitors the pressures, and we know, as you might imagine, kind of like with a water main or a water pipe, if you have increased fluid in there, you increase the fluid, it's going to increase the pressure, right? Just like if a water main were to burst because of increased pressure. So we know that pressure and fluid are correlated. So we know with these measurements, if the pressure measurements are going up inside a patient's body, inside their lung arteries, then that correlates or can correlate with fluid, and that will allow us to adjust medications, and then we can see those responses with those medications, and allow us to kind of manage these patients at home. So the CardioMEMS heart failure system has the pressure sensor monitor, which we've talked about already, about the size of a dime, goes into the pulmonary artery. There's also a electronic system. It's a little pillow. This is the traditional interrogator for patients and providers that know about ICDs and pacemakers and other devices. They have interrogators. You get interrogations at various clinic visits. So there's an interrogator for the CardioMEMS system. It's a little pillow that you lean back on. The pillow uses an RF signal to lock on to the sensor, and then extracts that pulmonary artery information as well as heart rate. And then there's a little cell phone inside the pillow that then sends that information to the web, to to a cloud server where we can, as providers, and in some cases patients, can see these numbers and see how their pressure and fluid levels are being managed. And then if they are in or out of range, then we contact patients and make medicine recommendations. That can be anything from dietary changes to increasing medicines or to decreasing medicines. Yep, Dr. Bouchard.
So let me backtrack a little bit. Let's say you're that patient. You talk to the patient in the office. You say, "We're going to admit you to the hospital to do this procedure." So where do you do that? This is done in the cath lab. What does it mean for the patient? How do you actually insert this device in the pulmonary artery?
Yep, that's a great question. So we identify these patients generally when they've left the hospitalization, or have been discharged from a hospitalization for heart failure. That's one of the criteria to get the sensor approved, is you have to have a previous heart failure hospitalization in the last year, as well as at least NYHA class 3 symptoms. So that is the baseline requirement criteria to get insurance to pay for the device. There's going to be some changes soon, which we can talk about a little bit later. But once you're deemed to be a candidate, we show you, the components to make sure that this is something that a patient can interact with, because there is a pillow, there is, some things that patients have to, be able to interact with. And if they are comfortable, then we get them scheduled for a heart cath. So it's all implanted the same way that we do what we call a right heart catheterization. So there's 2 types of heart caths done in the procedure ward for cardiology. Left heart caths look at the heart arteries. Right heart caths look at the pressures in the heart and the lungs, and on the right side of the heart. So we do a right heart catheterization through the right leg vein, and do a right heart cath, and we leave a little sensor behind in the pulmonary artery. So it's all done as an outpatient. Patient comes in the morning and then leaves in the afternoon. Generally, the entire process is about 4 to 6 hours.
So, Jason, can you give us some examples of pretty compelling cases that stick out in mind to you of where such systems have changed the game for, stuff you have been able to do that you wouldn't have been able to do before using such systems? Yes, absolutely. There has been a wealth of publications and clinical trials analyzing various patients with CardioMEMS, and really there's been kind of 4 major conclusions from all of these trials. One of them is improvement of quality of life and functional capacity. This is done with 6-minute walk tests and other functional measures. The second is decreasing heart failure costs, which is something that we talked about a little bit earlier. Third, and most importantly, is reducing heart failure admissions and hospitalizations. This has been shown time and time again. As a matter of fact, all the data continues to get even better than the original Champion trial in 2011, based largely on us just learning how to use this technology better and better. And then lastly, actually, there's been signals that it improves mortality as well. So it improves survival for heart failure patients, which makes a lot of sense if you are able to keep people out of the hospital. We know hospitals are, and repeated hospitalizations are bad in the heart failure world. So if you're able to prevent that, then you would lower mortality. So that's an exciting area for this sensor. Personally, we have seen several patients who have been what we call frequent flyers, in the hospital and in the medical world, where people are in and out of the hospital every month or every 2 months and have this repeated cycle of, being discharged and filling up with fluid again and then landing back in the hospital, and becoming very frustrating for the patient and their family as well as providers. So there's been several patients where we've been able to stop that cycle. We've identified them, through our EMR and through other ways as a high-risk patient with multiple hospitalizations. Identify them, bring them into the office, talk to them about the sensor, then, of course, being very interested in anything that would prevent them from having these repeated hospitalizations. Most patients are very, very interested in. Got the sensor implanted, and in a lot of these patients, they have yet to be hospitalized again in 2 years. So really, life-changing and life-altering procedures for these patients. Aside from the cost benefit, just the quality of life and the preventing hospitalizations has been a huge selling point and a huge key for our local program.
So typically, when patients with heart failure come in, we go through this entire education process. You know this very well, obviously, where check your weight, check your this. If it goes above this much, be careful. Maybe take some extra fluid pill. If it goes below this much, that's what traditionally is done. I'd say probably 95% of the country, right? And then there's this movement towards doing this remote monitoring, which is growing. So what does this mean for what we did before? Is it going to be like ultrasound and the stethoscope where you kind of get rid of it for most of the thing? Or is this just a case of, hey, listen, if we could have this for every single patient in the country, obviously you would have some kind of remote monitor. And with that, is there long-term risks of infection, in the artery, injury to the vessel? Is there a reason this is not, just exploding?
Yes, those are all great questions. I'll head to the complications, potential complications first. So there's virtually no risk of infection. There's been, I believe, over 10,000 CardioMEMS implanted across the world, and there's been no reported infection issues. I think part of that is number one, like a cardiac stent, like a heart stent. Once the sensor is deployed, after about 6 months, it becomes incorporated into the artery and re-endothelialized, like a cardiac stent. So there's really no exposed material. Plus, two, it is on kind of the arterial side, if you will, because it is in the pulmonary artery, even though it's on the venous side. So the increased, kind of flow prevents any sort of thrombosis and infection as well. So it's a very safe procedure, very little device complications. So going back, so very safe. So going back to the old ways of doing things, I probably should have emphasized this a little bit more. So why even do PA sensors? Why can't we just do weights? I'm sure everyone has seen that, my body weight went up 5 pounds. What do I need to do? Or I'm short of breath or my legs are swollen. So those are all important parts to, managing heart failure patients. But kind of the dirty little secret in heart failure is that we've known for a while that those signs and symptoms, number one, are unreliable. So the sensitivity and specificity or the kind of the metrics that we use to grade how well or not well a test is not great for the physical exam for heart failure. So the sensitivity and specificity for lower extremity swelling, for crackles in the lungs, even for JDP, some of the important things we look at on a daily basis are actually not good at all, meaning the physical exam can be quite misleading in heart failure patients. And multiple trials and studies have looked at this, and we all understand and know that the right heart cath, so internal hemodynamics, always tell the story for heart failure patients. We can be fooled. Even expert clinicians can be quite fooled with physical exam and other types of findings that we can do for heart failure patients. So really the only way to know for sure, and this is kind of what I always say, is to do a right heart cath. And that's largely believed in the heart failure world to be kind of the gold standard for measuring someone's, pulmonary artery pressures, fluid status, as well as their, cardiac output and cardiac index. So this is a way of, having basically what I call ambulatory SWAN. So Swan-Ganz catheter is the catheter that we use to get these pressures. So we have that internally and can access it multiple times a day if needed. And part of the problem why the physical exam, again, is not great is that by the time you start having symptoms, it's almost too late. We know that filling pressures increase, so pulmonary artery pressures increase, autonomic adaptation, so increased heart rate, and that sort of thing kind of happens next. And then you have intrathoracic impedance changes, so then you start developing kind of fluid in the lungs. And then only after those things do you actually have weight change and symptoms. And by then, you're only about 2 days or 3 days away from hospitalization. So being more proactive, kind of identifying some of these changes, 30 days, 20 days in advance and making changes before things advance is really where this technology shines. And And I'll just tell you, that we've had multiple patients where their pressures, their cardiomyopathy pressures start going up, and we call them up and tell them to increase their torsemide or increase their Lasix. And they're like, well, doc, I feel fine. I'm doing whatever I need, but we can see that even before they start feeling bad, all of these fluid and pressures are accumulating even before then. We get them on increased medicine and their pressures go down. So that was basically preventing a heart failure hospitalization right there. And we really do see this almost on a daily basis. So the whole idea of being proactive and not waiting until someone is decompensated or until someone is symptomatic is the way to go.
So, Jason, if we look at the ideal patient, or the ideal candidate, is a patient with a New York Heart Association Class 3, which means they're very short of breath on very minimal activity. I mean, kind of daily living at home, they're severely limited. Of course, a Class 4 is being short of breath at rest, but at least a Class 3, very limited, but also a patient that can engage, a patient that can communicate, a patient that can just kind of have a very good and strong relationship with their physician and their team, the nurse, right? Because obviously it's kind of you're remote and you try to kind of manage heart failure. They have to, first of all, be adherent to the technique of using the device, and which is basically pretty simple. It seems like the patient, once the device is in their chest, they just go home. They have this special pillow that has this little antenna, which communicates on the web at night when they're asleep. And basically, the doctor and the team looks at the data and can communicate with this patient on an ongoing basis, right? I mean, it doesn't seem to be any failure of these devices. There's no batteries. So like even the 10 and 12 years, I mean, these devices are still good if you're obviously careful about the communication device and don't drop it on the floor or break. I mean, it's a very reliable device, but you have to have the right patient, don't you?
Yes, that's absolutely correct. You do have to have the right patient. I think one of the most important things, so actually kind of getting back to what you're saying. So yes, this is a batteryless sensor. So unlike other implantable devices, they do not need to be exchanged. So that's one of the appeals to this, is that it lasts forever. It's actually powered on the RF current from the interrogator, and has no moving parts and does not have batteries. So it'll be in there and work, for the time that you have left, for sure. So we reassure patients of that, and that's very reassuring to them. I think one of the biggest things is with any device is that a patient understands, what it is and what it's doing, and if they're able to interact, appropriate with the device, so being able to handle the pillow, being able to do the downloads, being able to have a way to be contacted, and then most importantly, staying compliant with their medicines. So there are kind of a little bit of a screening process that we do, because not every patient is going to be a candidate, for this device, to make sure that they are going to get the maximum benefit from it. Because, especially if someone is not compliant or not interested, in their healthcare, we can only help them if they actually send downloads. And we have, unfortunately, have a few patients that have decided, not to do downloads and have decided it's been too cumbersome or too overwhelming. And those are kind of sad, because obviously if they're not sending us numbers, and we can't help them. So that is, one of the things that we look for is that, we have to work as a team. The patient has to do their part so that we can do our part. And then, of course, take their medicines. So there is a screening process. Now, getting back to what you were saying with NYHA Class 3 symptoms, it's a very kind of narrow patient population. So there's a great segue to one of the big clinical trials that is out, called GUIDE-HF. We're using hemodynamic guided management for heart failure. So because because Champion was so successful, Abbott has put forth the GUIDE-HF trial. So this is actually looking for the first time, looking at NYHA Class 2, so patients that are a little less sick, as well as NYHA Class 4 patients, so patients that are very sick. So because we did so well with the NYHA Class 3, patients. We wanted to see if this device would be helpful in patients that were not so sick and even more sick. In addition to that, they took out the requirement for a heart failure hospitalization and actually just left it at an elevated BNP. And it's actually even just a mildly elevated BNP for most of our patients, as a signal that these patients are higher risk than the normal population. So this trial had actually two arms. It had a randomized arm with 1,000 patients, which actually finished enrollment in December of last year. So we will hopefully see the results of that probably the first quarter of 21. They also had what we call a single arm, which was about 3,500 patients, where you can include them with just the elevated BNP and as well as a hospitalization if you wanted to. So we can see if just an elevated BNP in these patients with class 3 symptoms, if it would be helpful. So lots of exciting things coming with the CardioMEMS system, looking at an expanded patient population.
So one thing I recall when we did the Champion trial, this was gathering an enormous amount of data. And, you had kind of daily measurement and kind of weekly analysis of these parameters, biometrics that were measured online. It's obviously, it was quite a challenge into following patients with that amount of data gathering. How do you do that in your center? How do you handle all this incredible data? Who looks at this and how do you manage it?
That's an excellent question. And this is getting to what Dr. Ahmed was saying about why isn't everyone, doing this? Why isn't this more ubiquitous? And this gets to the real reason why. And a lot of talk in heart failure and cardiology circles. And as you alluded to, is the work on the back end of this. So yes, you have a lot of patients sending you downloads, and yes, you have to review all of this information, and yes, you have to make changes to patients' medicines, and yes, you have to contact them to make those changes. So what I've just outlined in a typical workflow is a good bit of work, outside of the typical healthcare setting, which is largely goes unreimbursed, right? So just like with anyone's job, people don't like to work for free. That's something that is not unique to physicians, and most people probably like to get paid for what they do. I will say that there are some minor reimbursements for managing devices remotely, but they really are kind of small, very kind of small dollar amounts. So what remote patient monitoring has become is really a labor of love in a lot of cases. But I think what the people on the front end, some of the early adopters of this technology have now shown is that in the era of COVID, in the era of not being able to see people in person, this has really brought remote patient monitoring and what we've been fighting for the last 2 to 3 years more to the forefront, realizing that just because you can't see a patient, or even if you can't be reimbursed for it fully, doesn't mean you shouldn't do everything you can to help somebody, to help a patient. I think that's really where it comes down to up to this point. It does take some staffing. You have to have a nurse or some sort of advanced practice practitioner, reviewing these numbers. We have very detailed algorithms in which these providers follow to help eliminate, a lot of guesswork and eliminate a lot of unnecessary calls to either physicians and guidelines for checking labs and that sort of thing to streamline the process. And that has worked. That's helped. But at the end of the day, you're going to have some patients that, need, another set of eyes and, some more thought, and that can take time. But I think Medicare and other insurance companies have done great to know that remote patient monitoring is, effective and important. And I think that with some of these new reimbursement codes and with some of the, the spotlight now on remote patient monitoring, I think there will be more people interested, not only from a physician standpoint, but also from a reimbursement standpoint as well.
Yeah, it's something we can talk about all day. I know we talked about this, was it recently with these new diabetes medications? It's a complex situation. I think all of us think the pricing of these things are ridiculous. in general. But at the same time, it's the same industries that are pushing the technologies and allowing the availability of these things to even happen. But if you were to go into a country like England with excellent healthcare systems, but realistically speaking, at no point anytime soon is there going to be a countrywide rollout of devices like this. One thing, we're going to ask you, what do you think the future holds for this? Is one part of that a drastic drop in price as this becomes more widespread? What's been your experiences with pricing and stuff like that? And another one, an important topic we've talked about recently. Seems to me that a lot of the patients that are at risk of heart failure hospitalizations are the same patients that don't have access to healthcare. And so, how does that? Would you say that a lot of the vulnerable populations, when it comes to risk factors, hospitalizations, and stuff, are they ever going to have access to technology like this? What are the programs and such that exist to allow those patients to be watched closer, whether it's monitoring with hardcore devices like these implantable monitors, or just other programs that allow people to be monitored, heart failure nursing programs and such? I think you're in an expert position to comment on that.
Yes, those are excellent questions. I think speaking to the cost of the device, so the device itself is around $20,000, which is an expensive cardiac device. Insurance usually pays for the majority of it, and there's a small copay for patients. So cost, like with anything, is always an issue. Now, they have done cost analyses, and these devices actually do end up becoming cost neutral at about 18 months, based on the healthcare savings and that sort of thing. So, we look at, when we're screening patients, you obviously, don't want to implant, someone who is on hospice or has, end-stage heart failure, that may only live, 6 months to a year. Generally you want, to target people that, have, a longevity to where they would be able to benefit from the device. Just like with anything in life and cost, competition is good, right? So as of right now, the only PA sensor on the market is CardioMEMS. But there is a second device called the Cordella heart failure system, which is also a PA sensor, which uses MEMS technology. So they are currently undergoing their clinical trial, which is called Proactive HF. So they have had several implants across the world, and we hope to be a big enroller for their clinical trial as well, because I think competition is always good. Not only does it make technology better, but it makes technology cheaper. And it's the same thing with medications. So I, hope that in the future, just like with anything, the cost will come down, which would be better for providers, patients, and healthcare systems. Back to your question about vulnerable populations, I think that the designers of trials have done a good job kind of trying to select the high-risk patients. So I don't see this, as a technology that would be for every patient. I think we identify high-risk patients on the front end that would benefit most from the device, which I think is what Abbott has done a good job and continues to do a good job studying with the Guide HF trial. So I think, over the coming years, we will have a really good idea, a really good feel for exactly the patients that would benefit from this device, so that we're not putting in an expensive device, needlessly in someone who may not benefit from it. So we're still kind of in the growing stages, trying to tease out exactly, who the right patient population is. But I think we're getting close. So I think that from a national health perspective, I think, this technology and this way of managing patients will continue to improve.
In the post-FDA approved trial, the CardioMEMS HF, pulmonary artery systolic pressure monitoring, it was they enrolled a lot of patients, and it was surprising to me that there was all kinds of heart function patient population. Some, when we were in Champion, your heart had to be very weak. The ejection fraction had to be less than 40%. But in the post FDA approval trial, about half the patient actually have a lower ejection fraction or pump function. You have almost 40% of the patient that have an ejection fraction that is normal. That means 50% of a normal pump function, yet they had an admission with heart failure, and they were class 3. So that was kind of interesting to me that actually some of these devices have been inserted in patients with normal ejection fraction. And yet in that study, which was post-marketing, they show a decreased hospitalization and decreased mortality, including even patients with normal ejection fraction. I mean, that's very powerful.
Yes, thank you for bringing that up, Dr. Guichard. That was actually probably one of the main importances or important parts of this device that I actually neglected, unfortunately. So HFpEF, or heart failure with a normal ejection fraction, which Dr. Bouchard's talked about a good bit in this podcast and previous ones. The CardioMEMS has the distinction of being the first and only therapy to be shown effective in HFpEF patients. As of to date, there is nothing else FDA approved. There's actually nothing else that's actually had a positive clinical trial in the HFpEF arena. But this device, specifically the CardioMEMS device, actually has. So this is the first evidence-based thing that we can actually do for HFpEF patients. And we've taken that to heart. I'd say probably about 50% of our patients that we implant with CardioMEMS actually do have HFpEF, so a normal ejection fraction. And we have seen that this can be very effective for patients because one of their primary issues is fluid retention. And they have a very kind of fine line between, being symptomatic, with fluid and with not. So the CardioMEMS is able to allow us to keep them very steady and very stable, to be able to keep them out of the hospital. So yes, and specifically in the HFpEF population, the reduction in heart failure hospitalizations was actually even greater than in the low EF patients. It was about 50% reduction at 18 months, which in the the overall patient population was 33% in the Champion trial at 18 months. So, I mean, even more effective, one could argue, in the HFpEF population. So yes, that's an excellent point that I left out before. Thank you.
Well, thank you. And it really seems like this monitoring is really helping kind of evaluate and address the fluid status in the patient. And it can be very difficult sometimes, and patients can be short of breath for so many other reasons, whether they have a low blood count and they're anemic or whether they have COPD. I think bringing these patients to the cath lab and do a right heart, evaluating the pulmonary pressure, and then, if appropriate, inserting a device like the CardioMEMS can really advance in the management of these patients. Now, there are some other devices, and actually maybe you could kind of describe to us some of the multi-sense technique where devices are placed or incorporated in the treatment of patients with heart failure, mostly when they need an ICD or when they need resynchronization or biventricular pacemaker. Jason, can you explain a little bit more about this resynchronization in patients with heart failure, and how's this device kind of help monitoring these patients?
Yes, so the second main device that's being used in the remote patient monitoring programs is a device from Boston Scientific called the HeartLogic. So it uses information from the implantable sensor, ICD, for both ICD devices as well as what we call CRT or cardiac resynchronization devices, uses sensors to predict impending heart failure decompensation. So this was a clinical trial called Multisense back in 2017 that led to its FDA approval for exactly that as a predictor for heart failure events in 2017. So HeartLogic uses a proprietary algorithm based on S3 heart sounds, which is amazing that these little implantable devices can actually measure sound. So it measures S3 heart sounds, which is one of the physical exam findings that we can see in heart failure patients. It measures the S3 to S1 ratio. It measures the night heart rate, thoracic impedance, respiratory rate, as well as activity. So it has this kind of combination of different sensors, this combination of different things, biometrics that the device analyzes, and then puts them all together into a proprietary algorithm and spits out a index And then based on the index, you can make changes to the patient's medical regimen. So there are recommended index levels at which you can make a change. Kind of the rule of thumb is an index of 16. So patients will just be monitored by their device until they reach an index of 16, and then that'll send an alert. So that'll send an alert to the provider or to the office. And you can take a look at that information. You can actually see which of the 7 parameters is what triggered the alert. So you can kind of maybe tease things out and kind of decipher if this is a true event or not, and then make a change. So this has been quite effective in our patients as well, partly because, these are devices that the patient has anyway, right? So you're basically just utilizing a device that is implanted for usually a different reason, like a low ejection fraction, or if someone's had a cardiac arrest and they already have the device, and now you've got a way of monitoring them. So we've kind of a 2-for-1 deal, so to speak. So we've been heavy utilizers of this as well, kind of capitalizing on devices that have already been implanted to be able to monitor some of our heart failure patients. And so there are ongoing trials as well, trying to look at the long-term effects of this device and some of its outcomes. And we're tracking kind of some of our internal data as well.
So you have a patient with heart failure and very low ejection fraction. On the electrocardiogram, they have a left bundle, and they're not an AFib. So they're getting a bi-V pacemaker. That means one of the leads of the pacemaker is in the left ventricle, one of the lead is in the right ventricle, and some patients will have also a lead in the right atrium. So these little devices to measure the heart sound, that we listen with the stethoscope, the S1 and the S3. So is that located in the left ventricular lead? And does that mean that a patient with a pacemaker just with a lead in the right ventricle won't be able to benefit from a special sensor like this? Or
yes, so a couple things. So it is a Boston Scientific specific device, and it's their HeartLogic capable devices. So not all of their devices are HeartLogic capable, but the majority of their ICDs and CRT devices are. Now that's an excellent question. Which of the leads or even the can or device itself listens for the different heart sounds? I'm not sure, actually. So I don't know if it's the leads themselves that listen to the heart sounds or the device or the can itself. But it does take, all of the, 7 parameters. I do know that the thoracic impedance is from the leads themselves, but the heart rate, specifically listening to the heart rate, I'm not exactly sure which part of the device listens for that. But it is incredible technology, and it is specific to Boston Scientific. But the other device manufacturers are coming out with their own versions as well. There's been mention that Medtronic is going to have their version, if you will, of HeartLogic here in the near future, which again, adds to the competition, which will hopefully lead to improvements of devices and lowering of costs. So, I think the other vendors have become very acutely aware that this technology and being able to monitor patients remotely has utility and has benefit. So this has prompted other vendors to look into their own devices and develop their own algorithms as well. So it's a very exciting time, kind of top to bottom in the remote patient monitoring world.
So where do you see the future in this? I mean, obviously we want to measure biometrics, in our patient, their heart rate, their blood pressure, their pulmonary artery pressure, the left atrial pressure. Where do you think the sensors or wearables are going?
Yeah, no, excellent question. So and of course I'm biased in this field because I'm intimately involved in it, but I think remote patient monitoring is here to stay. Just a quick little 15-second review, honestly, up to this point in cardiology and in heart failure, a lot of what has been done with, telemonitoring and other monitoring devices have actually been neutral. So we know that there's something unique. So there's been a lot of work up to this point in 2020, but there's something clearly unique with the CardioMEMS heart failure system and with the Boston Scientific HeartLogic Index that makes them different than everything that has been tried up to this point. So again, over time and perfecting technology, we now have systems in place that make effective management of heart failure patients outside the hospital a reality. So where I see this going is going to be more devices. We've already talked about one, the Cordella heart failure system as the answer to the CardioMEMS system, and of course Medtronic rolling out something similar to the HeartLogic device that Boston Scientific has. So I think revolutions in technology and in buying in by other vendors to increase competition is going to be good. Ultimately, I think one thing that's going to revolutionize the way we do things, and not only in heart failure remote patient monitoring, but also just in medicine in general, is going to be artificial intelligence and machine learning. So being able to automate more of this monitoring, where things become more computerized in the background. So an alert comes up, a patient needs a medicine change, your computer algorithm, machine-based learning, AI is able to identify that and, automatically contact the patient and recommend the medicine change, basically making things more timely, more efficient, and hopefully more cost-effective is definitely going to be, probably the leading edge of where remote patient monitoring needs to go. So this is again, I think kind of an exciting time. And I think we have a lot to learn, and there's a lot of room for improvement. And I think a lot of exciting things on the horizon for this important technology that I think is going to stay and is definitely filled a big need, even before COVID, but definitely after COVID-19.
Thank you very much, Dr. Guichard. Remote monitoring in patients with heart failure, and maybe one day, all of us. Thank you very much.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.